Today I'll be performing my video Osce for migraines. So we've been called to a 21-year-old female who has been complaining of a severe headache today. So can you tell me what's been happening today?
Just woke up with a really bad headache.
Okay. And have you had anything like this before?
Yeah, I do usually get migraines.
You do normally get migraines? Does it feel the same as your usual migraine?
Yeah, I think so, but maybe a little bit worse.
Okay. I'm going to ask a few more questions and do a few assessments. Is that okay?
Yeah.
Yeah. Okay. So what time did it start?
Oh, I probably woke up about half an hour ago.
Okay. And are there any provoking factors or relieving factors? Does anything make it better? Does anything make it worse?
I think when I move, it gets worse.
Okay.
But nothing makes it better.
Nothing makes it better. Okay. And for the quality of the pain, can you describe that to me? Can you explain what it feels like?
Yeah, it's just sort of like an ache behind my eyes.
Okay. And does it go anywhere?
No, just sort of this area.
Okay.
Yeah.
Okay. And how bad is it? So 0 being no pain, 10 being the worst pain in the world, what number would you give it?
Probably a 6 out of 10.
Okay, that's quite bad. So how often do you get headaches and how long do they normally last?
Oh, I probably get these headaches about a few times a month.
Okay.
Usually last a few hours, depending on if I'm not moving and resting.
Okay. And do you have any nausea?
No.
Dizziness?
No.
Any sensitivity to light?
Not really.
No. Any stiffness in your neck?
No.
No. Any recent traumas, falls, anything like that? No. And have you got good sensation in all your limbs?
Yep.
Yep.
That's fine.
Do your migraines tend to interfere with your day-to-day activities normally?
Yeah, they do.
They do. Okay. And do you have any past medical history that I need to be aware of?
No.
No? No, normally fit and well?
Yeah.
Okay. Are you on any regular medications?
No.
No. And what do you normally take for your migraines?
Just paracetamol and ibuprofen.
Okay. Have you had any of that today?
No, not yet.
No, not yet. Okay. Are you allergic to anything?
No.
No. And have you recently been exposed to any chemicals or anything different to usual in the last 48 hours?
No.
No. And you're usually fit and well when you aren't experiencing migraines?
Yeah.
Okay. So I've asked my off-sider to gain a full set of vitals and they're all within normal limits. So we're going to get her pain under control. So I'm going to give you I'd like to give you some paracetamol, ibuprofen and tramadol. You said earlier that you weren't allergic to anything. You're not pregnant at the moment? No. You said you haven't had anything, and just confirming you haven't had any pills or medications in the last 4 or 5 hours?
Nothing today.
No. She's obviously over the age of 12. Don't have any current paracetamol poisoning. So she's less than 80 kgs. So I'm going to give her 1,000 milligrams of paracetamol. I'm going to give her 400 milligrams of ibuprofen, and I'm going to give her 50 milligrams of tramadol. I'm going to document the time that this was given prior to giving it. Okay, so now what we're going to do is we're going to do a couple of assessments just to make sure that rule out a couple of things. So we're going to do what's called a fast test to start with. This is a test for a stroke. I don't currently see any facial droop. Can you squeeze my hands for me? Yep, and can you pull in my hands and push me away? Yep. I'm going to get you to turn your hands up towards the ceiling, and can you close your eyes and keep your hands there? Okay, perfect. And can you smile for me? Perfect. And I'll just do one more on your feet. Can you push up on my feet? Can you just stretch your legs out a little bit? Can you push up on my hands? Sorry. And push down. Perfect. So there doesn't seem to be any strength deficit. There's no facial droop. She can smile. So I can rule out as a stroke at present, as she doesn't have any of the positive symptoms. So now I'm going to do a test for temporal arteritis. So do you have any pain in your temporal region?
No, it's just behind my eyes.
Just behind your eyes. And it's not a persistent throbbing pain?
No, it's just an ache.
It's just an ache, okay. So I'm just going to have a bit of a feel. Is there any tenderness here when I do this?
No.
No. And I don't feel a decreased pulsation in the area. So as the symptoms don't align, I'm going to rule out temporal arteritis. Okay, so we're now going to do a cranial nerve assessment just to check out the nerves within your brain. It's a bit difficult to do all of them pre-hospitally, but we'll do the ones that we can. So the first nerve that we're going to assess is the olfactory nerve. This is difficult to do pre-hospitally as it's to do with smells. The second nerve is the optic nerve, checking visual acuity. So we're going to get our pupil torch out and we're going to check the pupils. So, okay, and perfect. So the pupils are equal and reactive. They are both the same. They're both the same size, and they are normal size, and both reactive to light. So, are you able to read this for me, please?
Emergency medical technician.
Okay. So she can read the epaulets. So I've ruled out that there's no optic nerve damage. The third nerve that we're going to do is the oculomotor nerve. So I'm going to hold my finger out here. If you can please follow my finger. Did you get any double vision, or were you having any trouble with that? No. I didn't see any nystagmus with that or any restrictive eye movements. The fourth nerve is the trochlear nerve, which we've already assessed previously. The fifth nerve is the trigeminal, ophthalmic, maxillary and mandibular nerve. This is assessing both sensory and motor and reflex. I'm going to lightly touch your forehead, your cheek and your jaw. Just make sure they feel the same. So I'll do this. Yeah?
Yep.
That feels the same. And
yep.
Yep. You felt all of those and they felt the same on both sides? So the sixth nerve is the abducens nerve. I've previously assessed her eyes. So the seventh nerve is the facial nerve. Okay. I'm going to be assessing for symmetry and power. Can you perform the following tasks? Okay. So if I can get you to please raise your eyebrows, close your eyes, blow your cheeks out, whistle for me.
Again, whistle usually.
Attempt to anyway.
I can't whistle.
Okay, try, just have a try. Perfect, that'll do. Can you close your lips nice and tight? These all appear normal. The eighth nerve is the vestibulocochlear nerve. I'm going to stand behind you and I'm going to whisper a number in your ear if you can repeat it back to me.
5.
Okay. The ninth nerve is the glossopharyngeal nerve. Can you swallow? Any problems?
No.
Okay. Can you cough? Any problems?
It's fine.
And she's talking to me fine, so this is all good. The 10th nerve is the vagus nerve. This provides motor supply to the pharynx, therefore good speech indicates an efficient vagus nerve, and she's had no problem communicating. The 11th nerve is the accessory nerve. Can you shrug your shoulders? Okay. And can you resist me? Yeah. We have no abnormalities here. The 12th nerve is the hypoglossal nerve. This is to assess normality, protrusion and strength. Okay. Can you stick your tongue out? And can you push it against your cheek? Yeah. And against my finger. So there's no abnormalities here, so I can rule out any cranial nerve damage. I'm now going to go through the red flag checklist within the CPGs. So this is under headache. Any manipulation of your neck recently?
No.
Of your head either? No?
No.
Any neck pain or stiffness?
No.
No. Was the headache, the onset of the headache sudden?
No.
No. Our vitals were normal. She doesn't have a temperature. Any persistent vomiting?
No.
She has no focal neurological signs. She has no altered level of consciousness. She's got no history of altered consciousness. There's been no trauma to the head. She's not taking any medication, so she's not on any anticoagulants. She's got no signs of temporal arteritis. She's not pregnant, so we can rule that one out. She's got no history of intracranial bleeding. She's got no family history of cerebral vascular abnormalities, and the onset was not during sexual activity. My following 2 tests are going to be physical tests, so if we can come over this side. Okay, so now I'm going to do a couple of other tests. If I can get you to lie down on the floor. The first test is a Brzezinski test. So I'm going to come behind you. I'm going to lift your head up. Any pain? No? No? Okay. So, I didn't witness any involuntary flexion of the knees or hips of my patient. She didn't have any neck stiffness or any cervical or thoracic pain. You didn't have any pain when you did that?
No.
No? Okay. So this is all good, and I can rule out, on this test, I can rule out meningitis as a potential differential. The next test I'm going to do is the Koenig's sign. This is for potential subarachnoid hemorrhage or meningitis. So I'm going to lift your knee up, and if you can tell me if there's any pain.
Okay. No. No.
So when I did that cause any pain?
No.
No. So this is a negative Koenig's test, and I can rule out meningitis or subarachnoid bleed. So all of our tests came back negative, so there's nothing concerning about her presentation today. There's no red flags present due to her symptoms being slightly different to her usual migraine pain. I recommend that she goes to see her GP in the next 12 hours. Is that possible?
Yep.
You'll be able to get in? Perfect, okay. And obviously if any new symptoms develop or anything becomes worse, you can call 111 again. And you can take your paracetamol, ibuprofen every 4 hours if necessary. Have you got some at home?
Yeah.
Yeah? Okay. I'm just going to go through a non-transport checklist. The patient has been fully assessed, including a full set of vitals and appropriate investigations. None of the vital signs are significantly abnormal. Serious illness or injury has been excluded. There are no red flags present. The patient has been seen to mobilise, and I will be leaving her a copy of her patient report form and an explanation of what I'd said previously about going to a doctor and what to do if it returns or anything gets worse. So my next video is for epistaxis. We've been dispatched to Lauren today, who's had an ongoing nosebleed for the past 10 to 15 minutes. I've instructed her to lean forward and keep direct pressure on her nose, nice and firm, and we will stay there for another 15 minutes and see if that stops the bleeding. If that doesn't stop the bleeding, we can use intranasal adrenaline as a pharmacological intervention. I've also instructed her to spit out any blood that has been dripping down the back of her throat, as it's not nice to swallow, and we don't want coagulating blood sitting in the back of the throat or going into the stomach. The nosebleed started suddenly today while she was in the gym. It's been a hot day and the aircon has been running in the gym. She's described it as it constantly dripping. She has a history of nosebleeds. They've happened previously when the temperature's been high. I found that she doesn't have any history of any previous nasal or cranial surgery. She's not on any anticoagulants, and she's not on any other medications, and she has no allergies. The vital signs that we previously obtained were all within normal limits. There were no abnormalities there. We can rule out hypovolemia, which is possible with any ongoing epistaxis and a large loss of blood. If the epistaxis was caused by a trauma, I would palpate her nose and her facial bones to investigate further, but this is not necessary today. Okay, it's been 15 minutes of direct pressure, so I'm going to check if it's still bleeding. Can you please remove the tissues? Okay, it is still bleeding at the moment. If you can put that back and continue to lean forward. I'm still seeing a continuous flow of blood from the nostril, so I'm going to escalate from a mild to a moderate epistaxis and use adrenaline as a pharmacological intervention. So we're now going to draw up the adrenaline. For epistaxis, we need to make a solution of 1 in 10,000. So that's 9 mils of saline and 1 milligram and 1 mil of adrenaline. We're going to draw that up in a 10 mil syringe, and we're going to give 2 mils into each bleeding nostril. So I'm going to get my offsider to drug check my adrenaline. This is an adrenaline ampule. Expiry is July 2020. I'm also going to get my offsider to drug check my saline. And this is July 2020 as well. Okay. Get my 10 ml syringe and my drawing up needle. Draw up 9 mils of saline. Make sure I've got no air bubbles. And then my adrenaline. One milligram of adrenaline. And label my syringe. I'm now going to draw up 2 mils of that solution to make sure I don't make any errors when administering the medication. So I'm going to draw up 2 mils. A bit of an air bubble in there. A little bit extra. 2 mils. I'm then going to get my mucosal atomizing device, swap the needles over to keep that aseptic. I'm going to, and my adrenaline is ready to administer. So I've drawn up my adrenaline and I'm ready to administer it. So if I can get you to turn towards me. So I'm just priming my mucosal atomizing device. Prior to administering this, not just yet, I'll get you to do it just before I give you the medication. I need you to spit any blood that's in your throat and blow your nose before I put this into your nose to get rid of any clots. Okay. So I will pop this, I'll get ready and I'll get to count to 3. And on 3, I'll get you to do a great big sniff. Okay. And this, I will squirt this into your nose. Okay. It may feel a little bit strange. Okay. So if you can spit. Blow your nose. Okay. I'm going to put this into your nose. And 1, 3, 2, 1. Okay. So we've administered our adrenaline, and we're now going to wait another 15 minutes and reassess, keeping your head forward and still squeezing the fleshy part of your nose. It's now been 15 minutes. You can remove the towel again. It looks like the bleeding has stopped and that the intranasal adrenaline has been effective. If the bleeding hadn't stopped, I could give another dose of intranasal adrenaline, and if it continued to bleed, I could also call for an R50 for backup, where they can use a nasal tamponade if they have one, or an ET tube can be used to stop the bleeding. So I recommend that you go and see your GP in the next 12 to 24 hours, especially because we've had to use some medication to stop the bleeding in your nose. And just for today, to try and avoid any hot showers, hot food or drinks, and avoid blowing your nose as much as possible for the next little while, just so that we don't rupture any of the clots that have formed and your nose might start bleeding. If your nose starts bleeding again, follow the same process, leaning forward and trying to stop the bleeding this way. If it doesn't stop and it has started again, you can call us back.
Okay, thank you.